two implant-free procedures to address all three potential points of resistance in the conventional outflow pathway. The device is inserted into the anterior chamber through a clear corneal incision. Once inside the eye, the trabecular meshwork is pierced to create an opening where viscodilation of Schlemm's canal can be performed. With the outflow channels dilated, a titratable trabeculotomy unroofs the trabecular meshwork and alleviates resistance, restoring healthy aqueous outflow. With all three potential points of resistance cleared of obstructions, the conventional outflow pathway can sustain healthy intraocular pressure to preserve the optic nerve and protect vision.
What I like about this is the smoother design, the ergonomics, the mechanics of just pushing the wheel forward to advance the ribbon is very helpful and very intuitive compared to the previous design. And it's smoother through the anterior part of the design. So I think it will be easier to teach to fellows because it's all about the grip. It's the feel of the instrument, especially a new instrument. It's got to feel right.
Has the right balance between the firmness to control the insertion and the flexibility to be very easy to use. The curvature is well designed, so it's very easy to find the right angle, and once it goes into Schlemm's canal, instead of going in little bits and pieces, you can take your finger and just slide it all the way. I can do 180 degrees in almost in one pass.
The Omni surgical system. When efficacy matters, choose Omni.
A very good day to everyone. Welcome to the WGC Symposium on To Mix or Not to Mix. My name is Chalvin Sung, and my co-chair, Dr. Ike Ahmed, needs no introduction.
Hi everyone, this is Ike Ahmed from Toronto. We want to welcome you to the symposium To MIGS or Not to MIGS, where we're going to talk about controversies in MIGS and comparative approaches to MIGS procedures.
We have a very exciting program with excellent speakers from all over the world lined up for you.
Our first speaker is from Italy, Antonio Fea, who will argue for filtering surgery always beats MIGS. This will be followed by Mitchell Lawler from Australia, who will argue against filtering surgery always beats MIGS. And Ricardo Paletta from Brazil will speak on trabecular bypass, KDB versus trabectome.
Dr. Paul Harasimovich from Canada will be speaking on GET versus viscodilation. And Dr. Leon Au from the United Kingdom will discuss the iStent versus Hydrus. Dr. Kawe Mansouri from Switzerland will present Zen versus Presoflow, while Dr. Yvonne Weiss from Canada will speak on the economics and ethics of MIGS. At the conclusion of the presentations, we will have a live panel discussion with all the speakers. Please send through any questions that you may have while viewing the presentations. We will start the talks now, and I hope that you enjoy the content.
Let's talk about the advantages of filtering surgery, which always beats MIGS. Okay, I've been in Italy known as an angel of MIGS, and I am cooperating with a lot of companies, but I have to play the role of devil here and say, step back, Trav is better. So what MIGS are we talking about? Well, let's take away the suprachoroidal, either because they are out of the market or not in the market yet. And let's talk about trabecular and Schlemm's canal. So there's no doubt that the average IOP is always lower with trab, and even if we take into account the standard deviation. So some of these patients might have a very low pressure. Still, there's no need to quote papers. TRAB is beating as far as lowering pressure any kind of mix. So we will have to go back to meds, and we will have the problems of the usual problem of medication, adherence, hypersensitivity, dry eye, and also there is some issues with precise control of IOP throughout the day. But the main problem with trabecular mix is the unpredictability of IOP in individual patient. And this is pretty clear if you look at the Goldman equation, and some of the variables here are not clear, are not possible to investigate by us. So we can actually end up with a patient with a low teen IOP, with a high teen IOP, or a pressure over 20 millimeters of mercury. And also there are other sources of variability that we can even be worse to investigate. So let's take away the trabecular mix. What about subconjunctival? For sure, it would be nice to have a controlled release of aqueous to prevent early hypothony. But do we really need this? Well, we have punch so that we can actually have a nice opening into the sclera. We can use releasable sutures or YAG suture lysis. And is this bad that we have to touch the patient after the surgery? Well, not at all, because this means that we can adjust our surgery according to what we found during surgery, and all these maneuvers are ambulatory. And to some degree, we can also prevent other problems like flat anterior chamber by using bandage contact lenses or patching. With subconjunctival devices, our only option is either needle, but this is more difficult to do than compared to TRAB. And you have the risk of cutting the device or displacing the device. And also, please note in the amount of bleeding which occurs when you needle compare when you take away a suture or when you laser it. The other potential option is to revise, but then you will have to have the patient in the OR, and displacing and cutting the device may happen again. And also what happens if the device is obstructed? Will you have to pay for a new device, or will you have to go for a trap? There are special cases when you have more challenges where MIGS can be advantageous, but there is no proven evidence. And also, with single-eyed patient, there is a faster recovery, which is much better for the patients. But even in this kind of patient, wouldn't it be better to use a procedure which is endorsed by a long clinical experience and you can actually easily adjust? When I was presented some of these devices, they said, you don't need any more mitomycin. So the result was that 8 of 9 patients that I operate in one day failed. And there is mounting evidence that you have to use a higher mitomycin concentration to obtain nice results in these kind of devices. Some also think that having intermediate filtration actually gives less fibrotic reaction, but please look at this video. Look at what is the difficulty of taking out the conjunctiva from the scarring tissue below. And also, when you revise a tube, you know that there might be a lot of scarring. There are also minor complications with this kind of devices, which are similar to the ones you can encounter with trabeculectomy, and others, like this exposure, which may be much more dangerous and might run undetected. Is there an advantage of doing glaucoma and cataract with this kind of devices? I'm part of this study. But why a small subconjunctival mix should obtain better result when in combo surgery and outperform the TRAB combo surgery? Is cataract worsening with these devices? There is no evidence, but if you read some of the papers, every time you have some visual acuity decrease in mixed paper, usually is because of cataract progression. What happens in the long term? Well, with a more controlled flow, a positive effect on the fibrotic process, is there any reason for that? I don't think so. And for sure, we would need to study much more the fibrotic control, whatever subconjunctival kind of surgery we will be doing. And what will be happening if you have to do a TRAB after a MIGS? Well, there's only one study, just on 8 patients, but they demonstrated that there was a higher than expected number of cases with low IOP and vascular blebs. So this again must be investigated more thoroughly. So MIGS are certainly fancy, but why should we go for an unknown path when we have this fantastic highway, which is tradition? So I really hope that I played my devil role nicely. And please note that I didn't mention the financial issues. These devices are actually more costly than doing a TRAB or any other kind of traditional surgery, and might have some issues with endothelial cell damage. Well, thank you for your attention.
Well, hello. I'm here to provide the contra case to the argument that filtering always beats MIGS, and so I'll try to argue that filtering does not always beat MIGS. In terms of disclosures, I've not received any personal funding, but our research group has an unrestricted educational grant from Glaukos to the University of Sydney. All right, look, always nice to start with a case. So let's have a look. This is a 45-year-old patient who has quite high pressure in that left eye, 25 millimeters of mercury. They've on maximal medical therapy, and they've had definite confirmed progression with structural on OCT and functional change with visual fields. And you can see that their disc is really quite cupped, inferiorly almost completely gone, and there's advanced superior and inferior arcuate defects. And so here, I think we'd have to think what's the best surgery for this patient, and really they need a big pressure reduction because they're way too high. They're very young, and so it'd be nice to get their medications down to 0 to reset that algorithm so that we have more time over their life to escalate as required. And they've got quite advanced field loss, so again, the target pressure is going to be quite low. So this is really a patient. Would we do a MIGS procedure for them? Well, I'd argue no. I mean, this person clearly needs filtration surgery because they want a big pressure reduction and to get them on many meds as possible. So filtration surgery definitely plays an important role, but what we have to do is work out for this debate, is it always the right thing, or are there some situations where MIGS may provide another option? So look, always good to go back to the data so we can see how to make our decisions in the best possible way. And we now have some great phase 3 trials, the FDA pivotal trials of a number of different MIGS devices. So the Hydrus was the first to publish, and you can see here that the cataract alone arm, 5.3 millimeter of mercury reduction of pressure, but with the device that went up to 7.6 millimeter reduction at 2 years. And then more recently, the iStent inject pivotal trial showed a remarkably similar set of outcomes with a very similar methodology in the study. And finally, although it has now been withdrawn because of safety concerns, the cataract with CyPass study also had a very similar finding. And these studies, when you look at them together, I think it does show us that cataract surgery gives good reduction. Adding an angle-based MIGS device gives an additional benefit over the top of that. So that's in the pivotal trials, in randomized controlled trials. What about in the real world? And that's some of the data that we're starting to see now in our registries group, where we have over 1,000 iStent inject patients. And you can see that after 12 months, we're seeing about a 20% reduction of pressure in the patients. All these patients have had cataract iStent inject. And this is not because of increasing medication usage, because you can see that at the same time, we're also seeing a significant reduction of glaucoma medications at that 1 year mark. So we know that this seems to be effective in the real world as well in a large series. So which patients then are we going to choose for thinking that MIGS is better than filtration surgery? Well, clearly this is a balance. So on one side, we have what is the outcome we're looking for. So like with that first patient, we were looking for a big pressure reduction and a big medication reduction. And on the other side of the equation is looking for or looking at what are the risks of surgery. And this is both patient factors. So, for example, is the patient a very high myope with a high risk of hypotony? And also something that I think is a little bit under-recognised is the surgeon factors. We know that each surgeon has a different rate of hypotony, and that probably should influence the surgery that we choose for our patients. So let's go back to the cases now to give us, try and work out who's the right surgery for the patient. So this is a lady who's 65. She's again on maximal medical therapy. she has a bit of early cataract and her pressure is at target. So pressures are 14 in each eye, which is where we want them to be. But you can really see from the photo there, she's getting a lot of allergy and irritation from the topical medications. So in this situation, what our goal really is to try and reduce the topical medications, but keep the pressure at about roughly the same level. And so here, I think this is a situation where really a cataract with an angle-based MIGS is a really excellent option in terms of not exposing her to the risks that do come with trabeculectomy, but trying to hit our target. And the last case we'll look at is another patient, very similar, 65, also maximal medical therapy with early cataract. And in this situation, the patient had pre-treatment pressures of about 19, and these were initially reduced, but over time they've started to creep up again, and now we're at about 17. So this is somebody who needs to have a small medication reduction, a small pressure reduction, but is tolerating their medications. And if we add into that they have a 30 millimeter axial length, and so the risk on the other side of the equation for trabeculectomy is relatively high, I think this is a person who would benefit quite well from a cataract with an angle-based MIGS procedure, at least to either delay trabeculectomy surgery. So hopefully I've argued to you that really there are roles where MIGS is better than filtration, or at least we should consider it, and particularly there for patients who need a topical medication reduction, or people where just a small intraocular pressure reduction is needed. And I've tended to focus here on cases with cataract surgery because I think that's where we have the best evidence for these MIGS devices. Thank you very much.
Hello. First of all, I'd like to thank the organizing committee for the invitation and congratulate the scientific committee for this great event. These are my disclosures. The surgical treatment of glaucoma involves a numerous of various techniques that we can aggregate in 3 large groups according to their mechanisms of action. And in the rehabilitation, conventional outflow or creation of a new outflow pathway or aqueous humor reduction. And the cahootable blade and trabectome, they are both of internal trabeculectomy techniques that we are going to share some thoughts about it. What is the rationale behind these techniques is that by removing the trabecular meshwork, the aqueous have direct access to the Schlemm's canal, eliminating the region that is believed to be the greatest source of outflow resistance. They use different approaches to the trabecular meshwork removal. The trabectome involves a 4-part platform with originally described mechanism of action of plasma surgery with a bipolar electrode that performs a cauterization and ablation of a nasal arm of trabecular meshwork. It has a irrigation aspiration tip that removes all tissue debris, avoiding inflammation and scarring. This also allows a good visualization as it aspirates all the blood reflux during the procedure. Some TM remnant leaflets may be left, and possible thermal injuries to the edges. The KDB uses a single-use ophthalmic knife. It has the 2nd generation version now. It's called KDB Glide, with more curved round edges to facilitate the slide within the canal. It creates a parallel incision in the TM, generating a free strip of tissue. The device has a ramp, which is designed to lift and elevate the TM prior to the blade, creating parallel incisions for tissue removal, theoretically providing a more complete tissue removal and limiting the damage to adjacent tissue. We can see a free flow of trabecular meshwork strip here in the anterior chamber. This is a preclinical investigation of both devices. As we can see, both of them provide the full thickness of trabecular meshwork ablation with no injuries to the adjacent sclera. But we see a difference in the removal of the TM, as here in the KDB, a more complete removal, and the trabectome, some tissue remnants here in the edges with some thermal injury. Concerning the IOP reduction capability, we see the both procedures provide very similar reductions in IOP. This is another preclinical study, a more recent one, where they evaluated the IOP and the outflow facilities with trabectome and Cahoop dual blade, and also with goniotome. And we see here with the trabectome some remnants of the tissue left here, while the Cahoop dual blade excises more complete TM removal. We see that both techniques provided reduction in IOP and an augmentation in the outflow, improvement in the outflow, but with a slightly better result for the trabectome in this animal model here. There is a trend in reduction in the number of traps over the past years, and there has been an augmentation in the number of MIGS procedures, and really an explosion on goniotomy in the Medicare beneficiaries in this study here. Almost 2,000% augmentation in the number of goniotomies. Here we can see this explosion of goniotomies, mostly performed by glaucoma specialists, but have a large proportion of them performed by non-glaucoma specialists. How does it compare with trabeculectomy? In this study, a large study, although it's a retrospective cohort study, we see that trabeculectomy provides a better results in terms of success rate and also in the survival curves, but with the cost of more complications than the trabectome group. Here we can see, departing from a very similar pre-op IOP and pre-op number of meds, we see that the results over 1 year are quite different, in the low teens for the trabeculectomy and the high teens for the trabectome, and a higher number of meds on 1 year postoperatively in the trabectome group. This is a prospective study on the Cahoop dual blade, where we can see that it provides a good control of IOP over 1 year of follow-up. When we see this recent meta-analysis on MIGS procedures, and we evaluate the comparison between trabectome and the Cahoop dual blade, we see that they provide very similar results in terms of IOP, and a slightly better result in terms of medication reduction for the Cahoop dual blade, although there is a shorter follow-up for the Cahoop and a longer follow-up for the trabectome. What are the advantages for the internal trabeculectomy? They're very safe, and safety profile, there is very close to phaco alone. Remove the trabecular meshwork instead of only incising it. This is a bigger advantage. There is a large body of evidence, although there is a lack of RCTs. The long-term data for the trabectome works well combined with phaco, and it's a device-free procedure. And the disadvantages are dependent on a good viability of post-trabecular structures, does not eliminate distal outflow resistance. Moderate efficacy outcomes limit indications to mild to moderate stages, and there is a cost when we consider the trabectome platform. Thank you very much.
Hello, my name is Dr. Paul Harasimovich from the University of Montreal, and today I was asked to talk about some pearls regarding comparing your patients with trabecular removal and stents in the eyes. These are some financial disclosures, and most of the devices we'll be mentioning, I've performed research with these companies. So very similar to as many salts are there in Japan, there's also many glaucoma surgeries available. There are many also in Schlemm's canal. We have a rich plexus of episcleral vessels. And the basic 4 mechanisms that we can operate for these patients are removal of the tissue, disruption of the trabecular meshwork, implantation of a bypass, or dilating Schlemm's canal with a device similar to the Omni. For patient selection, patients usually who are well controlled or slightly above target pressure are the best patients that present with cataract. This offers a chance to decrease the burden of their medical therapy. However, it's important to mention to the patients that they will probably still need medications long term. Trabecular removal can be performed usually in the nasal quadrant using either the trabectome. MST recently has some new devices for the trabectome machine. You can use the Kahoot dual blade. And the technique that we're using, which is low cost, is the 27 gauge bent needle called bang procedure. And this is great for developing countries where we can remove tissue at a fraction of the cost compared to other devices. Postoperatively, our patients will often have a little bit of hyphema, and this is to be explained to the patients, and we ask them to sleep upright. This white glistening tissue is actually Schlemm's canal, and this is postoperatively, but often our patients, electron micrograph is nice, but they develop broad PAS in about 10 to 15% of cases. So gonioscopy is very important. These PAS can then later be removed using the YAG laser. And we published on this in Journal of Glaucoma. So something important to note for your practice. Another side effect is that patients years later, such as this phacotrabectome, 2 years later, he presented with a microhyphema, a pressure of 40, and decreased vision. And blood reflux due to high episcleral venous pressure is one potential side effect. So patients that are lifting heavy crates or do yoga are not good candidates for this type of procedure. The gap procedure, we can remove either 180 degrees, 360 degrees of trabecular meshwork. And we usually reserve this type of surgery in our practice for young patients who are phakic, myopic, or perhaps uveitic that are well controlled, where the disease is mostly at the trabecular level. This can be done either with the fiboproline suture, which is less expensive, or with the iScience catheter cannula. Obviously, hyphema is one of the potential side effects. This patient with very advanced damage, despite his young age of 38 years old, has juvenile open-angle glaucoma. We performed GAT procedures. You see this nice white glistening cleft here. And postoperatively, with no medications, his pressures were 10 and 9. We published on this with Dr. Sahad and Salimi, and our patients usually will have pressures in the mid to teen range with very nice target low intraocular pressures, and up to 30% of our patients were medication-free at 1 year. Trabecular bypass stents are one of my favorite surgeries because there's minimal damage to the tissue. This can be done as was seen with the first generation or the second generation iStent inject. We start the surgery by marking where the collector channels are. We like placing them very close to the collector channels. And we feel this gives very good postoperative results. We see near the blue mark that we're nicely in Schlemm's canal with this iStent W, the wider version of the iStent inject. And we see spontaneous blood reflux at the end of surgery, confirming that we're in the proper position. Also in irrigation, the blanching of tissue says that we're also in excellent position. Postoperatively, one can also see aqueous humor outflowing through those episcleral venous system, and we have rated that and published on that. Our 3-year outcomes show that most of our patients can have mid to low teen pressures, and 46% of our patients were medication-free. This procedure can also be done in patients with PACG, with angle closure glaucoma after goniosyncytialysis. We recently published in the American Journal of Ophthalmology that compared to phaco alone, our patients had lower pressures and less medications. Potential side effects may include PAS developing, cyclodialysis, iridodialysis, and one must pay close attention to avoiding intraocular pressure spikes. The final device is the Hydrus microstent, which not only is a bypass, but also dilates Schlemm's canal, and when in proper position, looks like this. When compared to double eye stents in phakic or pseudophakic patients, there was lower intraocular pressure and less medication. And for patients that are allergic to many medications, this is important. All these procedures should not be done in patients with high episcleral venous pressure or patients who are at risk of moving. But definitely, this is one of the great choices for our glaucoma surgery patients. And we're happy to have these devices available for them. Thank you for your attention.
Welcome, everybody. This is one of the oldest questions in MIGS, if you like, whether you choose the iStent or you choose the Hydrus. and I've worked with both devices over the last almost 10 years. I've worked with both companies. Which one you choose depending on how you choose, I suppose. So if you just look at the design of the device, for example, you look at the Hydrus, and it's a significantly bigger device compared to the iStent. Compared to the iStent first generation you see in the middle, and also the current iStent injects. The Hydrus spans across the 3 clock hours. It dilates the Schlemm's canals, which have significantly bigger lumen, while the iStent offers you a single point entry to the Schlemm's canal, and you tend to place 2 of them, either with the old generation or the new generation, which is even smaller. So if you believe size matters and the bigger lumen should give you more flow, then this little paper published in IOVS kind of proved that point, that in an eye bank, a cadaveric eye situation, when you insert a Hydrus, because of a bigger lumen size, almost 5 times the lumen of a normal iStent original G1 version, the outflow on the benchtop appears to be significantly increased with Hydrus compared to the iStent. Both increased, but the Hydrus seems to give you more outflow increase than the original iStent, 2 of them together. And the current generation, which is the iStent inject, because it's half the lumen size of the original iStent, you kind of feel that maybe the original iStent does give you more outflow than the current inject. And certainly on the benchtop, it appears to be true. The inject, 2 of them, seem to give you less increase in outflow than the original iStents, which is then less than the bigger Hydrus device. But why would you choose the inject then if this is a smaller outflow? Well, that's because of the ease of use. There is no question that comparing to the Hydrus, the inject is far simpler and easier to use. It's beautifully designed, single handpiece, as you can see here, 2 stents loaded in one. You fire it in ab-internally through the meshwork into Schlemm's canal. And it is the most widely adopted MIGS procedure, both by glaucoma surgeon and also by cataract surgeon, which of course is a massive market. It is easy to do, as you can see in here, and it's not without some of the downside the injects because of the firing mechanism. I think one of the downside of the injects is the fact that you can over-implant the inject. You fire straight through the meshwork into canal and bury the injects. As you can see here in the pictures, although you can see 2 injects, the bottom one is actually fully buried and over-implanted. And in fact, some work here done by my good friend Kawi and Andre Mahmoud in Lausanne show that the efficacy of the injects really does depend on the position of the inject, where it sits in the canal, assessed with the OCT, and beautifully shown that some of the injects does seem to be over-implanted. So I'm excited about the current version, which is the iStent Inject W, which has got a much wider flange, and I think it really solves the problem of over-implantation. Because it's so wide, you are unlikely to over-implant. So then now you can confidently be able to deliver 2 stents at the right place, rather than the old inject, we may find that one stent is in, the other is not. So I think we're going to see better results coming out of the iStent inject and more user-friendly. And there is no 2 ways about it. I think the Hydrus stent, despite the design advantage potentially, it is a harder device to implant. You can see in the bottom video here, you do need to keep your hand pretty steady, cannulate the Schlemm's canal, and it doesn't always cannulate that well. And it takes a bit of practice, takes a bit of getting used to. And I do feel deep down that certain angles, certain canal may not suit the curvature of the Hydrus. You can see here at the top right, maybe that I'm struggling to get the Hydrus into the right place, and it seems to want to dive down. I readjusted and I retried, and it's still diving down almost below scleral spur. And some days you will hit those once in a while and you can't get it in, and unlikely to get that with the iStent. But if you look at the FDA study, when you want to look at the results, then they all have the similar FDA trial. They all have the similar mild to moderate glaucoma patients, phaco versus phaco mix. They've all shown either the iStent, the Hydrus, even the CyPass, they're adding a mix, increase your chances of success. And for the iStent, it increased your chances of success by about 13.4%, while the Hydrus was almost increasing it by 20%. In terms of washout IOP, the iStent inject seems to give you an extra 1.5 millimeters of mercury drop compared to phaco alone, while the Hydrus give you 2.3. So based on the clinical study on the FDA trial, the Hydrus seems to win out. And in fact, this is the first head-to-head comparison in a randomized controlled trial, multi-center, comparing a Hydrus single device versus the old iStent G1 as a standalone procedure. Ike, Antonio, myself, and many people were involved in this trial, and we managed to demonstrate that Hydrus is just that little bit more efficacious compared to the iStent. So if you believe in Cochrane, Cochrane has reviewed most of the MIGS devices in terms of the iStent and the Hydrus, and I think Hydrus is the only one that Cochrane has given a favorable review to say there's moderate certainty evidence that Hydrus is adding something extra to cataract, while the iStent actually received a low certainty evidence. They also go on to say that there's moderate certainty evidence that the Hydrus is a bit more effective than the iStent. So let's finish on a one little high note for the iStent is the fact that the iStent's been around for a long time, longer time than the Hydrus. And myself, we published this 7 years outcome of the phaco iStent, which does show that even over 7 years, pressure stays down, medications reduce, visual fields are stable, and more importantly, you get to see the patient less often. They require fewer follow-ups after the procedure, showing you some long-term success. So there you have it, my 6 minutes rundown of iStent versus Hydrus. Depends on how you want to choose. That's based on your preference, based on the product availability, often based on the company support in your area, which company you prefer to work with. Reimbursement plays a big part, and also the individual patient's need. Thank you very much for listening.
My name is Kaveh Mansouri. The topic of my talk is Zen versus Preserve Flow. These are my disclosures. A few words to the Zen gel stent, which is a cross-linked gelatin stent. It's 6 millimeters long, has an inner lumen of 45, and it was CE marked first in Europe and then approved by the FDA in 2016. The Preserve Flow, initially in focus microshunt, is slightly longer, 8.5 millimeters. It has a larger inner lumen of 70 microns and a different material called SIPS. Probably due to the longer duration on the market of the Zen, we have more literature available, about 151 results on PubMed for the Zen versus 34 for the microshunt. Now, in essence, if you want to resume where Zen seems to be leading is that we have more data, we have longer term follow-up, and most of those studies are investigator-driven. Where the Preserve Flow leads is that we have the only randomized controlled trial of a MIGS device to standard filtration surgery, trabeculectomy. Now, I've chosen a few interesting publications to share with you. One from our group that looked at the 3-year results of Zen gel stent published last year. They had data available from 92 eyes, meaning about 62% of the initially included patients. At 3 years, average IUP was at 13 millimeter mercury, which represented a 37% IUP reduction from baseline. Medications were significantly reduced from 1.9 to 0.5. Needling was required in 55% of cases. And we also found that risk factors for failure were male gender, diagnosis of primary open-angle glaucoma, and the need to perform needling. Of interest, we found that most patients who were controlled after the first year continued to be controlled after 3 years. Another study, the multi-center APEX study, was just recently published its 3-year results. It was a multi-center retrospective study that had data available at 3 years for 46% of initially included patients. And they also had an average IUP similar to ours, 13.9 millimeters, and they found an average IUP reduction of 33% from baseline. Medications were statistically significantly reduced, although to a lesser degree than our study, from 1.9 to 1.1. And needling was required in 43% of cases. And about 12% of patients required secondary surgical intervention. Now, what about the evidence for Preserve Flow? Different studies, sponsored studies by the manufacturer, have been available. An important one is a non-randomized 2-year post-market surveillance study, multi-center, including 100 eyes, which found a success rate according to the definitions of almost 70% after 2 years, and an average IUP reduction from baseline of 34%. Now, for those of you who attended the last World Glaucoma Conference and the Consensus series, or who have been reading the book, you remember that one of the consensus statements was that MIGS are now established as an alternative surgery in glaucoma patients. And importantly, that we require high quality randomized controlled trial data. Therefore, I think this study from the preserved flow compared to trabeculectomy, multi-center study in the US and some European centers is of great importance. And the results were published just the other month. 2 years results, or the only 2-year follow-up study, although only the 1-year results were published so far, included 395 eyes undergoing microshunt compared to 132 eyes trabeculectomy. In summary, the authors found that trabeculectomy was superior in terms of success rate, in terms of IUP reduction, as you can see here, and in terms of medication reduction, superior to microshunt. In terms of safety, both groups were similar to each other. Now, what about Zen versus preserved flow? We don't have a head-to-head comparison between the two. An interesting study was published again very recently from the Netherlands. That was a retrospective study comparing 41 eyes with Zen to 41 eyes with preserved flow. The follow-up was not very long, a minimum of 6 months, and they had more combined phaco-Zen or phaco-MIGS procedures in the Zen group, 37% compared to only 2% in the preserved flow. And they found a qualified success rate of 73% in the Zen versus 79% in the preserved flow group, and the difference was not statistically significant. As you can see in this graph, the two groups were quite similar in terms of IUP reduction from baseline, in terms of medication reduction from baseline. And also when it came to adverse events and the safety profile, no important and statistically significant differences were found between the two groups. So the authors concluded that the two devices were similar in terms of efficacy and safety. Of course, this was a relatively small retrospective study, and you are all familiar with the biases of such studies. However, it is at present, to my best knowledge, the only study comparing the two to each other. Based on which, and I would say also based on my own experience and others, we can conclude for now, I would say, that the two devices are similar in safety, similar in efficacy to each other. However, of course, a definitive answer needs a head-to-head comparison to give solid answers. Thank you.
So far, we have learned about how some MIGS compare to others. I'd now like to switch gears a bit and talk about the economics and ethics of MIGS. I have no disclosures. It's such an exciting time to be practicing surgical glaucoma. We've seen a huge increase in innovation. The challenge is, how do you decide on one device over another and in which patient? And how do you stay away from the issues associated with innovation bias, the presumption that new technology must be inherently better? We're supposed to base our clinical decisions on solid clinical studies with good statistics. This is called evidence-based medicine, a term that was coined by Dr. Gordon Guyette from Canada. The problem we face is, can we trust the evidence? We all know, or we should know, what is a good clinical trial. This publication by the World Glaucoma Association, which is also available free online, goes through various aspects of sound methodology for the conduction of glaucoma. We did a study where we compared or looked at clinical studies of MIGS, which were compared to other procedures against various outcomes which were defined by the guideline to see the level of adherence. Today, I'm going to be focusing on two of these areas, ethics and economics. I would encourage you to read the article, though, in its entirety, because I think you would find some of the findings very interesting. Starting with ethics. We usually always consider conflicts of interest when we talk about ethics. And you can see that the studies actually did very well in disclosing their conflicts of interest. And that's enough, or is it? Conflicts of interest can really affect how studies are designed and transparency of results. Would you be surprised to know that 90% of the RCTs were funded by industry, or that the majority of the studies had an author that was related to industry, or that 60% of the RCTs had authors that were shareholders of the devices they were reporting on? Now, receiving funds for doing a study or being a consultant for a company is one level of potential financial bias. But being a shareholder when the published results of that device may directly influence your share price is a whole other ballgame. Also, 60% of the RCTs had industry employees that were authors. The World Glaucoma Association is one set of guidelines really specific for glaucoma surgeries, but we have other guidelines for conducting surgical trials or trials in general. And this is CONSORT, the Consolidated Standards of Reporting Trials. None of these studies adhered to CONSORT. Now, for those of you who have been in practice for a while, you'll remember the prostaglandin wars. We've been down this road before. In this study, we looked at abstract conclusions because, quite frankly, many people don't get beyond the conclusion or the abstract when they read funded studies. 62% of the abstract conclusions were not defended by the results of the study or supported by the results of the study. So a quarter of the industry-funded studies had a statistically significant main outcome measure, but 90% of these had a pro-industry abstract conclusion. This is not lost on many of us, and you have comments like this appearing in chat groups. There is the elephant in the room of enormous financial reimbursement and encouragement for the use of MIGS as a go-to intervention. Some of this responsibility, however, also should be shared with the journals. Journals are the gatekeepers of what is published. In this study we did, looking at conflict of interest disclosure by journals, in ophthalmology journals, they were very poor for peer reviewers and editors. I think we might be crossing the line where some of the papers that we see are product promotions or advertising versus peer-reviewed scientific studies. The issues with ethics can transcend all areas of study design. And in our analysis, there was less than a 50% adherence to the outcomes from the World Glaucoma Association guidelines. And for me, one of the more shocking ones, it was the definition of success for a surgical trial. Only 1 in 5 of the outcomes were adhered to. In Canada, healthcare is delivered by a single government payer. And the government, quite frankly, has been very slow to endorse MIGS. The Canadian Glaucoma Association went to CADTH, the Canadian Agency for Drugs and Therapeutics in Health, to ask for an independent evaluation of MIGS with a hope that this would encourage government to support them. Well, the CADTH conclusions were that the evidence is lacking, both for the relative benefits of any MIGS device or procedure over any other. They also made a comment, there is a disparity between the existing quality of evidence on the clinical effectiveness of MIGS and the belief in its value manifested in the adoption of MIGS by Canadian specialists. Current usage of MIGS in Canada is not strongly evidence-based. Another important consideration in surgical devices or in also all aspects of clinical care is economic evaluations. We only have so many healthcare dollars. In Canada, with a population of 37.5 million, in 2019, the government spent $265 billion on healthcare, with the top 3 areas being hospitals, followed by drugs and physicians. If you look at this graph on the right, you can see the annual percent change in health expenditure shown in blue and the consumer price index in green. You can see that healthcare expenditure is increasing faster than the CPI, and this is clearly not sustainable. Economic evaluations are important. They will affect the patient, the physician, the policymakers, and payers. They also have an ethical implication. What is the point of having devices or medicines that are not affordable to the majority of the public? What are the ethics behind that? In Ontario, Canada, they did an assessment to see if the government should fund MIGS, and their conclusion was against publicly funding MIGS for a variety of reasons, including uncertainty in the evidence. When they tried to evaluate cost effectiveness compared to medications, they were only a 60% cost effectiveness at a willingness to pay of $50,000 per QALY. MIGS were not cost effective compared to filtration or laser surgery. And in Ontario, with a population of 14.6 million, the estimated additional cost to the healthcare system was $6 million in 1 year and up to $70 million in 5 years. So I believe in the potential of these new technologies, that they do have some position to play in the treatment of glaucoma. However, we need stronger evidence and more oversight on the potential role of industry and on study designs and the transparency of results, and we need good economic assessments. If we had uniformity in study designs that was adhered to by parties, it would allow for better transparency of results and also to compare one study to another, one device to another. And I think the journals should get together and play a leading role in this. Thank you.